Hi, I'm Dr. Robert Silverman, Amazon best-selling author of Inside Out Health and host of Proven Health Alternatives. Today's guest, Dr. Robert Kachko. He was outstanding. He shared some great clinical takeaways about the psychological aspects of pain. We had a great give and take, naturopath, chiropractic, all about health. It's a must watch. Hey everybody, Dr. Rob Silverman here, Proven Health Alternatives. I've got naturopathic doctor, which we're going to talk about, extraordinaire, Dr. Robert Kachko. How are you?
Very good. Thank you for having me, Dr. Rob.
I am excited to have you on. We've talked on the phone a whole bunch of times. Your reputation, without question, precedes you. So many people have told me you're the guy to talk to as a acupuncturist and a naturopathic doctor. So I want to read your bio to everybody so they get a little background on who you are and what you do.
Sure.
Dr. Kachko, naturopathic doctor, licensed acupuncturist, is Inner Source Health's expert in cardiometabolic risk reduction and chronic pain. Without question, he's a leader in the fields of naturopathic and integrative medicine. Dr. Kachko has combined the core principles of Western and Eastern approaches to care into a comprehensive biosocial methodology for people dealing with chronic disease. An advocate for healthcare reform, he is the incoming president of the American Association of Naturopathic Physicians, AANP, and currently serves on the board of directors for this organization. A native New Yorker, my man, without question, he has also served on the board of directors of the New York Association of Naturopathic Physicians. He is the CEO and founder of Tribe RX, a comprehensive technology-enabling solution for people dealing with chronic pain. So it sounds like you know a little something about pain, my friend.
Yeah, it's been the focus of a lot of my work for the last couple of years, especially with Tribe, and I suspect we're going to talk about that in a bit. What I really found was this work in chronic pain sort of found me. You tend to get out of medical school and have this idea about the patient population you want to work with and the values that you espouse in terms of your medical care. And then what ends up happening, and I hear this over and over from other docs, is the patients who need you find you, and then you end up changing your approach. And so I still do a lot of that cardiometabolic stuff. I've done a lot of work in the Alzheimer's realm, but the chronic pain community has really come through. And I think it's because we get results. And so that's been very true. But I've also heard a lot of really important and empowering patient stories through our work with Tribe and what we're doing with the startup as well.
Fantastic. So what's the role, or what is the role of the social connection in health outcomes? I know we talked about it a little before we went on.
Yeah, no, that's a great question. And I think it's a question that's not being asked often enough these days. I would go so far as to say that social isolation, lack of support, and lack of understanding are the biggest public health epidemic that no one is seeing, no one is knowing. And if I would backtrack a couple of years in sort of my interest in all this work, I was doing a lot of research and a lot of speaking on the topic of psychosocial health and how it contributes to physical health. And what I was seeing in the literature was that it was as dangerous to be lonely or to perceive yourself as being lonely as it was to smoke 15 cigarettes per day. It's 2 times more dangerous for our health, for our likelihood of early death, than it is to be obese. And we know what the risk factors are for obesity across the board for chronic disease. And so I tried to make sense of that for myself. And I tried to put that into context of other types of public health concerns. We look at air pollution and alcoholism, and truly social isolation and lack of understanding, lack of support beats all those out as a contributor to early death, unfortunately. And so that paired with this understanding, and around the same time I was working a lot in the world of nutrigenomics and precision medicine, and we were working on a startup at a certain point. I understood that medicine is heading in this direction where you're going to go to your doctor and they're going to have all your genetic information, your microbiome data. They're going to have all your blood work available, and you're going to put your symptoms into a symptom questionnaire on some screen, and out will pop the most precise, the most personalized treatment plan for your needs. The challenge there is that the healthcare experience is already a very dehumanizing experience, and I felt and understood things were moving in that direction. So yeah, I'm super concerned about the role of social isolation as it contributes to health outcomes. If we looked at statistics in the 70s and the 80s, somewhere between 10 and 20% of people specifically 11 and 20% of people would say that they feel like they don't have enough support in their lives. And that's important. And we understand that that contributes on an evolutionary level. It contributes to our health outcomes. It contributes to our likelihood of developing heart disease and cancer and Alzheimer's. But unfortunately, we haven't really found ways to address that effectively. And in 2019, more people would say that they have no one to turn to in a time of crisis than even one person. So this isn't something that's going away, and we can have a whole separate podcast on the role of social media and all that, and sort of using that as a means to an end in an ineffective way. But the latest statistic I saw in a large scale study was, if we look at our senior population, 43% of seniors would describe themselves as lonely or isolated. It's a real problem.
That's a major problem. More to talk about the connection and the social connection and the isolation and pain. Do you want to expand upon that just a little bit?
Sure. So for context is a little bit of my view on pain and sort of if we take this biopsychosocial view of pain, it's not just about the biomechanical structural model, though of course that's important. If someone has something structurally wrong, or if their gait is inappropriate, or if they have something misaligned or muscle tension somewhere, that needs to be resolved. The question becomes, though, are we addressing the psychosocial aspects effectively for people who are dealing with chronic pain? And I would go so far as to say that if we address those psychosocial aspects effectively, people's pain, if they come into us and say, well, doc, my pain's a 9 out of 10, maybe their pain would be a 3 out of 10 if they felt supported, if they were considering their physical condition from the right perspective. We're going to talk a little bit about pain personality and sort of who comes into our door. But what's true is that if we take the social part of that psychosocial component of biopsychosocial care, that's a mouthful, what we find is that the neurobiology of physical pain and social pain are actually very similar. Beyond just saying, okay, my arm hurts and this is how it hurts, and some part of this is the severity. This is it's a 2 out of 10 or a 9 out of 10. The suffering that we experience around pain is really connected to a couple of important brain regions like the ACC, the anterior cingulate cortex, the anterior insula, and the prefrontal cortex. These are 3 really important parts of our brain that help us decide how important something is and how much of a threat it is to our well-being. And the research shows that physical pain activates those brain regions and causes us to suffer as a result. But social pain, being excluded from a group of people who we know and trust, being excluded from a group of strangers, whatever it might be, activates those same brain regions. And so we have an opportunity in healthcare to give people the right support, to give them the connection they need so that the biological, biomedical, structural treatment is more effective. It's essential. And to take a step a little bit further back, it all makes sense, right? So if we, through our evolutionary history, were separated from our tribe and we felt alone, of course our lives were at risk. We were in danger of being picked off by whatever saber-toothed tiger, and our evolutionary mind was the threat. That was more dangerous to us than being away from food or water. It turned on the same mechanisms, the inflammatory mechanisms, the oxidative mechanisms that we all know about. It turned on our likelihood to have tenser muscles. It turned on our likelihood to send blood flow away from our digestive tract. There's so many different reverberations of this idea of not feeling supported and understood that I'll say again, social pain and physical pain are inseparable.
That's so fascinating. Social and physical pain are so inseparable. Most people consider everything physical, and nobody, patients, when I say nobody, typically considers it social, which kind of leads me to the next question. Working with patients say to me, I have a high pain threshold. Others say they don't. It's kind of come to the point where I was wondering, is there such thing as like a pain personality?
There really is. And so if we look at the types of people who come into our door who are more likely to have chronic pain, there's really 3 core components of that. One is those people feel low levels of what's called self-efficacy. They don't feel like they can help heal themselves. They feel like the only fix for their pain has to come from their doctor or their surgeon, and they're helpless other than that. And so that means they don't make the changes they need to to get better sleep, to improve their digestion, to move differently, to drink enough water, to change their diet, whatever it might be. Number one, low self-efficacy. Number two, they tend to catastrophize their pain. So what that means is, well, I hurt my back and I'll never be able to work again, or I'll never be able to play with my grandkids, or my life as I know it is over. Number three is this tendency to what the researchers call hypervigilance, being vigilant to the world and feeling like the world is dangerous. The example that I give, everyone knows someone who has a pretty quick startle response. You walk into the room and it kind of scares them. They're sort of on edge, on guard all the time. And the alarm system is really turned on very effectively and very easily. So those are the three components of a typical pain personality: low self-efficacy, likelihood to catastrophize our pain, and hypervigilance. And what we find is that all three of those mechanisms, again, turn on those same brain regions that contribute to our likelihood of dealing with chronic pain. And so the solution to that really is education, helping people to understand the role that pain may play in their lives, helping people to understand the fact that just because something hurts doesn't mean that they're actually continuing to do damage by movement, because as we know, one of the best indicators of helping people move from an acute situation to avoiding a chronic situation, especially with something like low back pain, is how quickly they get back to their normal routine and to normal exercise. And so we want to teach people within reason, once they've been checked out by their doctor, that movement is essential. And to do so, they need to understand that movement won't continue to cause damage. And so there's this whole growing field of pain neuroscience education, this idea that if we teach people the difference between acute and chronic pain, we teach people the difference between a body that's in pain and a brain that perceives pain in a certain way, which we can talk about more in depth, people actually get better. Just teaching people about pain actually reduces their pain, which is an incredible thing.
So we have to educate our patients, and people in America should be educated about the concept of pain.
Yeah. And importantly, they have to be educated about the fact that, and we're right in the middle of New York City. So if you guys are hearing sirens,
I'm loving the sound. It's
happening
like
in real
time.
time.
I got you.
7th Avenue, right where we are. We absolutely have to provide education for our patients. First and foremost, we have to help them understand what pain is and how the body perceives pain, and how the body and the brain are always working together to help us understand pain within that context. But then beyond that, we have to help patients understand, and this is a paradox. This is one that was hard for me to understand and wrap my head around until I saw the research and started working with people dealing with chronic severe pain. And it's certainly a difficult one for patients to understand. Beyond this idea that patients are told often their pain is just in their head, which, what a disempowering idea that is, right? What opportunity are we giving people to heal if we're telling them directly that we don't believe what they're dealing with, that they're making it up, or it's because of their depression? That's not true. Pain is experienced certainly in the brain, but there's a strong interplay between brain and body. That said, though, one of the biggest challenges is 100% focus on complete elimination of pain. If you have a patient, or if a patient walks in my door who says, I won't be happy until this pain is 100% gone, I need to go back to the life I had before this pain. Unfortunately, that's not always realistic, and paradoxically actually makes the pain worse. It makes it more likely that pain will be chronic and long-term. And so the flip side of that, to put more of a positive note on it, is finding a new value system. There's this whole field of psychotherapy called acceptance and commitment therapy. And the word acceptance is hard for people to wrap their head around. How can I just accept that I'm in pain and just continue to live with this? That's not the idea. The idea, though, is finding new values and a new value system, finding new things that bring us joy, or remembering the old things that used to bring us joy that we've forgotten about, and actually reaching out towards those and feeling those again, and allowing ourselves to bask in those values. Again, that approach, a focus on quality of life as opposed to 100% elimination of pain, is a really important concept in pain education.
That's great. That's great. It's interesting how much but they don't understand. Like, a lot of new interns come out and say, what's the number one thing I need to do? And I tell them that they need to educate their patients. Speaking about that, we have a common ground in a lot of things, but one of the things that I think that we have the strongest common ground is movement and movement's impact on pain levels.
Mm.
So for me, a break in movement is not only a mechanical break, it's a biochemical break. And I know for you, you've added some components to that statement.
Yeah, I fully agree. It's biomechanical, it's biochemical, and I would say it's neurological. If our brain is having difficulty integrating movement effectively, it can turn on the same alarm systems that a physical pain will cause. And so let's just step back and talk about what I mean by an alarm system. We learned really early on as children not to put our hands on a hot stove because that sent a reflex to say, hey, that's dangerous, don't do that again. And we learned pretty quickly not to do that. The same thing happens with chronic pain, except we learn to experience something as an alarm that might no longer be an alarm. Once we've been dealing with pain for 12 or 16 weeks, sometimes up to 6 months, the original injury or the original illness, whatever the source of the pain was, very often has healed. But pain still remains, and that pain remains in our brain and in terms of how our body perceives that pain and in terms of how we're experiencing it. The challenge is our brains are very complex. Nothing happens by mistake, and they're smarter than us. They're smarter than our conscious understanding of what we're attempting to do and our understanding of how the world is working around us. And I think probably the best way to explain this is through an example. If you have chronic neck pain and you have trouble turning your head 26 degrees to the left, and all of a sudden at 27 degrees you have pain, well, our brains are sending an alarm system to say, don't do that anymore. That's dangerous for us. So maybe at one point it was dangerous to turn your head 27 degrees to the left because you had some kind of joint issue. And our body learned, well, instead of allowing this idiot to keep turning his head 27 degrees to the left, let's stop him at 24 degrees. Or let's stop him at 18 degrees. And that continues to build on itself because our brain sends a signal through our musculature to say, let's send a signal of pain at a certain degree of rotation before that person continues to cause actual damage. And that becomes a learned mechanism that builds a vicious cycle. And so over time, one of the worst pieces of advice that patients are still getting every day is, you've got pain, stop moving that joint. The worst thing that can happen, because what we're doing is we're confirming that bias that our brain has. We're confirming this idea that movement is dangerous, and our brains truly are movement machines. And there's a lot going on that integrates effective movement through the work of our frontal lobe and our cerebellum and our vestibular system. Well, there's a lot of integration that has to happen. And if any of those systems aren't working effectively, that can also send a trigger of error. And I mentioned earlier this idea of the anterior cingulate cortex. That's the part of the brain that experiences the suffering around pain. Put another way, that's the part of our brain that tells us there's something wrong, something needs to be done. And it's also the part of the brain that says there's an error somewhere. It's the like smoke alarm in our brain. Something needs to be fixed. And so inappropriate movement, to your point, inappropriate gait or whatever that might be, can send that same alarm system even if there's structurally nothing wrong at all. And so the remedy to that is helping people to slowly, within environments of relevant safety where they feel relaxed consciously, to help them relearn effective movement. Sometimes with some patients who have really severe chronic pain, that actually starts just with visualization, visualizing certain movements, then gradually moving to full range of motion where you're actually rotating your head all the way to the left. So it is biomechanical, it is biochemical, and it certainly affects our metabolism. I think it's also neurological and our brains attempt to protect us, which is basically all life is for certain parts of our brain.
That was great. I love the neurological component. Lorimer Moseley, he's an Australian pain guy, says pain is not a sign of a destruction, but is more a protective device.
Yeah.
I think his statement speaking to what you just said. So,
and actually, can I bring up a really
absolutely.
Study? So Lorimer Moseley in 2007, his team did a trial where they separated two groups, and their hand was exposed to a probe at a certain pressure that would cause a uniform amount of pain, but everyone had the same amount of pressure. And one group, the probes were colored red, and the other group, the probes were colored blue. And across the board, the people who were exposed to a probe at the same temperature and the same pressure that was colored red experienced more pain, all else equal, than the ones who are colored blue. And so you ask, why might that be the case? Our brains have learned through our evolutionary history that heat is more dangerous to our body, to our well-being, than cold is. Heat could kill us, cold kills us a little bit more slowly in extremes, right? And so our brains also perceive red as hot, more of a new idea since we've had, faucets with hot and cold and all that, and blue as cold. And so that one factor alone changed people's perception, and they experienced more pain. And so you think about that one tiny factor, think about all of the negative self-talk that we have about our pain. And again, that idea of catastrophizing. We can have a whole nother podcast on the role of physical trauma and emotional trauma on pain. That all imprints and that impacts our perception of pain. And so back to that idea of a pain personality, a lot of that is contextual. It's based on what we've been exposed to, what we've been taught, the language that we've used. So much so, I think one of the most interesting and curious findings in history, before the Berlin Wall came down, I know this seems like a tangent, but I'll bring it full circle. Before the Berlin Wall came down, East Germany had almost no chronic low back pain, and West Germany had a bunch. Didn't make sense. There was just a wall there. What was the case? Structurally, obviously, the people were the same. You could maybe point to ergonomics and gait and learn mechanisms like that. But the fact is, after the wall came down, it took just a couple of years where the rates of chronic low back pain actually equalized across all of Germany. And so it's clear at that point that it's about the way we talk about pain, the context within which it exists. So whether it's a red or blue light, or the language that our doctor uses when we go to them and they say, "Oh, you're broken, only I can fix you with my scalpel," all of that contributes to your likelihood of dealing with long-term chronic pain.
I agree. I think words are stimuli. For me, pain isn't an issue. I don't like heights. So I don't like to go to the top of a mountain. My wife and I were just on a vacation. We were driving up, and the driver says, "Oh, we're going to the top of a mountain and going around a cliff." And that's all I needed to visualize before we got any incline. I asked to stop and go around. So I understand exactly what you mean. That's my pain. But you're right. Color, words, conversation are without question stimuli. It's interesting. You're a naturopath, and so many of my patients have tried naturopathic, and a lot of people want to know what it is. So why don't you tell me what's a naturopath, or what's the difference between a naturopath, a naturopathic doctor, and a naturopathic physician?
Great question. So the answer is it depends. It depends on the states within which we're licensed or not. So NDs, an ND is a trained primary care level physician who went to a 4-year medical school. NDs are not licensed in every state in the U.S. We're about half of the states right now, and we're working on it. There's a push.
That's a shame. That's a shame.
It's a shame. We're working on that with the American Association of Naturopathic Physicians. I've done work specifically with the New York Association of Naturopathic Physicians to really modernize that and change that up in Albany. The fact is, in states where we're not licensed, there's no what's called title protection. So anyone can call themselves a naturopath or a traditional naturopath. And look, there's a lot to be gained about people learning about nutrition and changing their mindset and reducing stress. And certainly, especially if we're seeing this whole movement of health coaching, there's a lot of benefit to be gained. And there's a time and a place for all types of approaches. But the challenge is in states where we're not licensed, the consumer patients, potential patients, don't really have an opportunity to know the difference between a naturopath or a traditional naturopath and a naturopathic doctor or naturopathic physician, which is, again, someone who went to a 4-year medical school. Very often, the residency requirements are different in every state. Very often completed a residency, much like any of our MD and DO colleagues. And in many states, we're functioning with full scope authority. And so it's amazing that you can go across the border between Connecticut and New York and experience such a drastic difference in access to care. My perspective, and of course I'm biased, I'm incoming president for the ANP, but my perspective is that unless NDs have a seat at the table, our health challenges will not be resolved. And these public health epidemics that we're facing of obesity and poor nutrition and skyrocketing rates of diabetes and Alzheimer's, these are all preventable chronic diseases. NDs are the physician level providers trained to help you prevent and reverse those chronic diseases. So I really recommend that if you haven't heard of an ND, check out naturopathic.org. We have a Find an ND link on there. You put in your zip code, and the nearest licensed or licensable naturopathic physician or naturopathic doctor, depending on the state where we're working, would be happy to help you. And so I encourage you to reach out and reach out to me. I'm sure my email will be in the show notes. If you have any questions about naturopathic medicine, it's a passion of mine to ensure that naturopathic medicine is a household name in this country. So feel free to reach out.
You know what? Now that you brought it up, we didn't get it at the end. We'll get it now. I got your websites. So why don't you give your websites, and we'll make sure we put it in at the end also. Give your websites, your IG, your Facebook. Go for it.
Sure. So my practice is at Inner Source Health. It's www.innersourcehealth.com. You can find me and my colleagues there. The chronic pain related startup that we've been working on, this psychosocial augment, is called TribeRx, TribeRx.com. You can find me all across social media. I'm new to that game. I'm definitely learning the value of that quickly over time if done right. And so you can find me on Instagram at dr.kachko, Kachko, so Dr. Kachko. And then on Facebook, it's much the same. If you put in my name, you can find me there. So I'm out there, focusing on the work in the trenches to get us licensed and all those things as well. You
were talking about Tribe X. I want to give it some justice. I want you to talk about that. But before we jump into that, what about you? How'd you become a naturopath and acupuncturist? I always tell the story that chiropractors, naturopaths, we're very similar in orientation. I went to Bridgeport, a chiropractic school and a naturopathic school. But we're typically unique, naturopath and chiropractors, in that we were touched. We were touched by somebody and we decided to do it. No one had brain surgery and decided to be a brain surgeon. No one got arrested and decided to be a police officer. So I'm sure you've got a little, quick little story of how you became a naturopath and acupuncturist.
Yeah. And my experience was actually very similar. And I think it's a testament. Many of my classmates, to your point, they saw naturopathic medicine work for themselves or someone they loved. And very often people would go in after having worked a different career and all that. So I think that's a testament to the power of the medicine. My story was very similar. I was an EMT in high school around the same time when we were learning to take pulses and all that. I had an arrhythmia. So I was 17, went to the cardiologist. Fortunately, they had no answers for me. They basically told me, avoid caffeine. If you ever start fainting, come back, but we don't really have anything to do to resolve that. That wasn't enough for me and my family. We just wanted more answers. We actually went to a Chinese medicine practitioner. To this day, I don't know what he did. He practiced in a very naturopathic medical sort of way. I wasn't really inquisitive prior to, but I certainly became inquisitive after the fact and sort of went back to the cardiologist, and they said, whatever you're doing, keep doing that. The arrhythmia is gone. Good news. And so that just opened my eyes to different approaches to the body. I probably read way too many medical anthropology books for a 17, 18-year-old kid at that point to learn about different approaches. Though around the same time, one of the challenges as an EMT that I was facing was, our job was to get people to the hospital and to keep them alive. I had no opportunity to hear the patient's story. I had no opportunity to understand what the circumstances were around their life, aside from a car accident that brought them into that emergent acute state. And so I wanted to be a part of people's journey a little bit earlier. I wanted to have the opportunity to spend time with patients. And so I get to do that now as a naturopathic doctor. First visits with me are an hour and a half. Follow-up visits are typically an hour. I have an opportunity to really join in people's journey and be a part of their lives and their stories in that way. And so that really resonated with me. But then beyond that, I think I inherently always knew that the food that we eat, the water that we drink, and the thoughts that we have the capacity to change our body and to prevent chronic diseases. So when I found naturopathic medicine and Chinese medicine, I decided to study both. So 4-year naturopathic medical degree, 3-year master's in acupuncture, whole lot of school, lots of sleepless nights, but glad to be here.
I feel your pain, my friend. It's that vivifying look. I feel your pain. I remember that. My first semester, I did it all nighter. I'll never forget that. I was so proud of my grade, but my body did not like that. That's a great story. Like I said, we've been touched, chiropractor, naturopath, by somebody to bring it in. So if somebody had to do 3 things, the Dr. Rob's 3 things, just because we discussed pain. Give them 3 things before we sign off that you would recommend to decrease their incidence of pain.
Reduce inflammation, however you can find an opportunity to do that. Always starts with diet, right? Get high quality sleep. REM sleep and slow wave sleep are super restorative. And then change your mindset around pain. Can I do 4? Exercise and movement, effective movement, and tracking your movement effectively is important too. So I'm going to cheat and say 4. But the 4th is an umbrella one, and it really speaks to a lot of what we spoke about earlier. This idea that we have to change our mindset around pain. We have to feel like we can pain-proof our bodies. We have to feel like the healing can come from us and not just from our doctor. We have to reframe the expectations around pain and really focus on living a quality of life. So mindset makes movement and diet and exercise and sleep much more effective.
Well, there you have it. You have Dr. Rob's 4 pain-proof ideas. Great time. We got to do it again. Anybody who needs anybody in New York City, they're all yours from me.
Yeah, appreciate that. Right across from Penn Station. That's why we're here in Illinois out there. Yeah.
Down on Penn Station, right by Madison Square Garden. My man, my Knicks.
Looking at it out the window right now.
Yeah, you probably have a better shot of hitting a jump shot than they do, but let's not go there. I saw that face. That was a pain face.
Yeah, you're killing me now.
Oh, goodness.
Bring Van Gundy back.
Yeah, I got you. I'm a Knicks fan, diehard New York City guy, just like you. So we're going to sign off. Everybody, it's been great. Any questions, feel free. You can write in the comment section. We'll get Dr. Rob to help it. So I'm Dr. Rob Silverman, Proven Health Alternatives, always yours in health.